Hello, everyone. This is Kathy Bush, and welcome to the DandleLION Medical Webinar on the Creating and Sustaining Transformation, Evidence-Based Best Practice. We're so pleased to have Mary Coughlin as our faculty presenter today, and we also have Kathy Randall with us to provide technical support and help with questions at the end. So Mary is an inspirational speaker, motivational coach, and transformational consultant with a clinical background that spans over 30 years. She has pioneered the concept of trauma-informed care as a biologically relevant paradigm for hospitalized newborns, infants, and their families. An internationally recognized expert in the field of age-appropriate care, Mary has over 35 years of nursing experience, beginning in the U.S. Air Force Nurse Corps and culminating in her current role as President and Chief Transformation Officer of Caring Essentials Collaborative. Mary is a published author of myriad number of transcripts, chapters, and textbooks. She has mentored close to 10,000 interdisciplinary NICU clinicians from over 14 countries to transform the experience of care for the hospitalized infant and family in crisis. We are so lucky to have her with us today. So Mary, welcome, and we can't wait to hear your information.
Well, thank you very much. I'm really honored at this opportunity to share something that's really near and dear to my heart. Over these past few years working with Caring Essentials, I've really been pretty obsessed about the idea of transforming the culture of care and having that impact the experience of care of the hospitalized infant, family, and the clinicians as well. And so when I was invited to do this talk, it really resonated with me. So I hope you find this interesting and also practical. As many of you know, if you've ever heard me present, I'm a little obsessed with videos, so I do have several videos planted throughout the slide deck. If it makes you cuckoo house, I apologize in advance. Let's get this ball rolling.
So I do a search for Theodore Roosevelt in 1910, and the quote that came up changed my life, and it's the Daring Greatly quote. It's not the critic who counts. It's not the man who points out how the strong man stumbles or where the doer of deeds could have done them better. The critic belongs to the person who's in the arena, whose face is marred with dust, sweat, and blood, who strives valiantly, who in the end may know the triumph of high achievement. But when he fails, he does so daring greatly. And so three things totally shifted in my life that moment. The first was, that's who I want to be. If we want to be courageous and we want to be in the arena.
Guys, for the technical glitch, I really wanted to play Brene Brown's talk about daring greatly because I feel it really sets the stage for this topic at hand. For any of you guys who have already embarked on improvement initiatives, transforming care, even just PDSA activities, I'm sure you've encountered pretty much what Brene describes. Not necessarily Twitter thugs per se, but folks pushing back. I affectionately refer to these folks as Barbara, but those people that kind of become the fly in the ointment and can really thwart your efforts and make you feel like you're banging your head up against the wall. Probably one of the most important evidence-based best practices around transforming culture is really finding courage that lies deep within you to understand the urgency and the importance of the work you do. So as we go through the rest of the slides, what I hope to do is really highlight three tactical best practices, but also three best practices around reflection that really underpin your ability to operationalize the tactics. So, I kind of want to set the stage here with introducing you to this idea of habits and the importance of habits. And I think many of you can really understand where I'm coming from when you come on shift, or I won't point my finger at you guys. I'll just tell you, when I would come on shift, I had a very clear routine. It was mindless, my routine. I would come in, jump off the elevator, walk past Zelda, say hi or good morning, go through the double doors, march all the way down to the end of the corridor, into the triage room, which is where we have the assignment board. I'd look at the assignment board, see what room was I in, which babies did I have, and who was I working with, and that basically set the stage for the rest of my day. It was a habit. I did this all the time. I didn't have to think about it. I mean, if I was sleeping or sleepwalking, my body would just do this. This was my default setting. We all have habits, right? We have habits around our 8-11-2-5s, flipping and stripping the baby. We have all of these habits that when we first, were introduced into our clinical practice, they were new, they were interesting, and we were probably pretty present for them because we were trying to process them and assimilate these actions into our routine. But over time, they become habits. And the definition of a habit is when a conscious decision becomes an automatic behavior. And 40% of the actions that people do every day aren't real decisions, they're habits. And so kind of understanding that definition, I'm going to just throw this out to you guys to think about what are some of the habits that you have in your clinical setting. And, you can write them down on a piece of paper, or you might not even need to do that. But just think about how many things you do over the course of the day that you don't really think about. Right? And I'm going to show you on the next slide, and hopefully this won't bomb on me. But a very common habit that we have in our work, particularly when we're looking at improving clinical practice, transforming care, is what Brene is going to talk about here. Kathy, let me know if there's a problem with the audio.
Okay.
How many of you are blind? How many of you, when something goes wrong, the first thing
Not hearing it.
Hi, my name is Brene. I'm a
Fudge.
blind. Years ago when I first realized the magnitude of the blame.
Okay.
I'm in my house. Whoops. How many of you are blamers? How many of you, when something goes wrong, the first thing you want to know is whose fault it is? Hi, my name is Brene. I'm a blamer. Let me just tell you this quick story. So this is a couple of years ago when I first realized the magnitude to which I blame. I'm in my house. I'm on white slacks and a pink sweater set, and I'm drinking a cup of coffee in my kitchen. It's a full cup of coffee. I drop it on the tile floor. It goes into a million pieces, splashes up all over me. And a millisecond after it hit the floor, right out of my mouth is this: damn you, Steve. Who's my husband? Because let me tell you how fast this works for me. So Steve plays water polo with a group of friends. And the night before, he went to go play water polo. And I said, hey, make sure you come back at 10 because I can never fall asleep until you're home. And he got back like at 10:30. And so I went to bed a little bit later than I thought. Ergo, my second cup of coffee that I probably would not be having had he come home when we discussed. Therefore, and so the rest of the story is I'm cleaning up the kitchen. Steve calls, caller ID. I'm like, hey. He's like, hey, what's going on, babe? What's going on? So I'll tell you exactly what's going on. I'm cleaning up the coffee that spilled all like dial tone. Because he knows. How many of you go to that place when something bad happens, the first thing you want to know is whose fault is it? I'd rather it be my fault than no one's fault. Because why? Why? Because it gives us some semblance of control. But here, if you enjoy blaming, this is where you should stick your fingers in your ear and do the na-na-na-na thing, because I'm getting ready to ruin it for you. Because here's what we know from the research. Blame is simply the discharging of discomfort and pain. It has an inverse relationship with accountability. Accountability, by definition, is a vulnerable process. It means me calling you and saying, hey, my feelings were really hurt about this, and talking. It's not blaming. Blaming is simply a way that we discharge anger. People who blame a lot seldom have the tenacity and grit to actually hold people accountable, because we expend all of our energy raging for 15 seconds and figuring out whose fault something is. And blaming is very corrosive in relationships, and it's one of the reasons we miss our opportunities for empathy. Because when something happens and we're hearing a story, we're not really listening.
were in the place where I was, making the connections as quickly as we can about whose fault something was.
And how many of you guys have had that kind of an experience, you know, related to some kind of a practice improvement or a change in care or some kind of initiative that you're working with? That something happens, you thought everything was going great, and all of a sudden everybody's doing the practice that they, you know, the old practice, and haven't really continued to sustain the new practice. And then you get all angry and frustrated, and you're blaming your colleagues, or you're blaming Barbara, or you're blaming the administration, or you're blaming the docs, or you're blaming somebody to say, this is why it's so frustrating here. We just can't do anything. Nobody cares, and blah, 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 blah. Sound familiar to anybody? These are some of the things that really, they kind of undermine our opportunity to really transform the experience of care and transform the care in a sustainable way. We need to shift from an emphasis on the techniques for improvement, and don't get me wrong, they're super important. It's absolutely critical that folks have a very clear understanding about quality improvement methodologies, how to use the PDSA cycle, how to measure, you know, and benchmark your where you're starting from, and monitor and measure your ongoing success. You know, that the old adage that what gets measured gets managed is true. And so we need to understand that bit. But if you only focus on that aspect, you are going to be so sorely disappointed. And you're going to be like Brene in the previous video, blaming everybody for why things aren't going on. So shifting to a focus on habits, and remember what I had said in that earlier slide about the definition, these are decisions that become automatic behaviors. And so you may be sitting there now thinking, well, this is bizarre. What the heck, what habits are you talking about, Mary? And these are really the habits that I'm talking about. And what I would like to do, if you guys are interested in the slide deck, is I'd like to share the accompanying paper that really gets into this in detail. It's an open access paper that talks about the habits of improvers. The habits of improvers are really about those elements of you that when you dig down deep, really expose themselves as your passion, your core values around why you do the good work that you do. And one of the things that I really loved about this particular paper and this model is that similar to the 5 core measures, which I'll be introducing a little bit down the road, this also highlights these 5 core habits that improvers have. And those 5 core habits are the words that you see on the periphery of this circle. It's about learning, it's about influencing, it's about your resilience, your creativity, and being a systems thinker. And then you see all of those little projections off of the circle. Those are those sub-elements that really reflect that core habit. So when you're an influencer, when you have that capability, you're empathic, you're facilitative. And I know this is a tough one. It certainly is a tough one for me, but you grow to become comfortable with conflict, because conflict is that thing that happens just before you have a breakthrough. Now, I'm not talking about, you know, pounding each other's, you know, heads against the wall and that kind of a conflict, but that conflict that helps you grow as the influencer to understand and gain insight about the other, but also it's that other person's ability to then start seeing what you're seeing. And as I get further down in the slide deck, we'll discover some more cool tactics that will help you cultivate that. Your level of resilience is really kind of that courage that you create and you nurture and you grow, and that is framed by your passion for doing this, being optimistic. It's so easy to splash around in the mud and with everybody else about how miserable it is in your unit and how bad it is and blah, 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 blah. And, you know, the old adage, you know, what you resist persists. So if you continue to feel that that's your world and you don't do anything about it, well, knock your socks off and continue to be miserable, and you won't make any improvement. You won't be able to be part of that solution. You need to be comfortable with uncertainty. Creativity. I had the most amazing experience working with Children's Healthcare of Atlanta over a 3-year period, and I got to meet the most amazingly creative folks. They completely blew me out of the water. And a lot of it is just, you know, again, turning inward and discovering what are the things that you enjoy about your work. How can you create a situation that is going to be fun and engaging? That's using your creativity. It's working with others. It's creating ideas, but not getting married to your ideas. Because when you get married to your ideas, things don't change. Being a critical thinker, having critical thinking skills also aligns with that level of creativity. I'm going to jump systems for a second and look at that learning dimension, that learning core habit, always questioning. And in the work of Bernadette Melnick, you know, all that stuff around evidence-based practice and practice improvement really challenges us to wake up out of our day-to-day habits in the clinical setting and say, gee whiz, is what I'm doing today really the best for this patient? I mean, this is what I've been doing for the past 30 years, but is it really the best today? And you all know, I mean, there's just been this burgeoning volume of amazing evidence, particularly around trauma-informed care and the evils, if you will, of toxic stress and early life adversity, that it gives us the opportunity to ask those questions and probe and investigate the research, look for solutions, and reflect on how is this new information going to help me improve the service that I provide to others. And certainly you start that reflection at the individual level, but once that light bulb goes off, then it's that opportunity to take this new habit and apply it into your improvement initiatives. The systems thinking really helps us as frontline clinicians understand how we connect the reality that we have in our day-to-day work and in serving others and what are their needs, but connecting that to what is of interest at that C-suite, kind of rising above the bottom line, if you will, that, you know, we're not two different sides of the coin, that we're all on the same page. We just are speaking different languages. So when you cultivate that habit for systems thinking, you're always looking at connecting the dots, making a connection between a facilitated gentle nasogastric tube insertion to patient satisfaction or to some other metrics that your hospital is focusing on. So that's these are these 5 core habits that, you know, you have to cultivate these, just like any kind of a habit. But as I go through this, I think you're going to discover that you have the power inside of you, and many of you don't even realize that it's there. So these tactical best practices to create and sustain practice transformation really evolve. The influencing, the resilience, the creativity, the systems thinking, and the learning really evolves from that core question that you must ask yourself is why? Why do you come to work every day? Why do you do the work that you do? And you really have to reflect on that authentically, because if you are uninspired by the amazing work that you do, if you are disconnected from your passion, you really need to take a step back and reconnect if indeed you are going to be an effective change maker and you're going to be able to create and sustain transformation not only at your personal level but at your unit level and even beyond your unit. You really need to reconnect with that why. And that's part of that daring greatly that Brene talked about at the beginning of this slide presentation. I'll just tell you a quick story. I remember when I first transitioned to clinical practice from the military, and I was working at the Brigham, and I loved doing triage. So the role of triage was the nurse that got to go to all the deliveries. Now, mind you, they were high-risk deliveries, but we had some pretty loosey-goosey criteria around high risk. It was also a teaching hospital, so you could get called for a delivery with meconium-stained amniotic fluid, and that would be considered high risk. Or if they had septic risk factors or something. So, so I get called to a delivery, and again, I loved doing this, and I got called earlier, than I probably needed to be there. But of course, I'm there, I'm at the warming table, and I could not help but get caught up in the birthing of this new baby with this family. There was, the dad there, obviously the mom is there, some extended family, I don't know who's who, obviously the OB, and we were at that active stage. She was pushing the baby out, and I found myself eventually, I'm clutching onto the side rail of the warming table, literally clutching it, and inside, I hope I wasn't saying it out loud, but I was also saying, push, push. And, the baby gets born and everybody's crying. And of course I'm crying, but trying to be cool about it. I wipe off, I wipe off the baby once they brought the baby over to the table. I wasn't down at the other end. Bring the baby over, let mom and dad kiss and pass the baby around and feel the joy. And then unfortunately I had to take the baby up to the NICU. And as I was traveling up the elevator, I just got awash with the joy that is the work that we do, or at least that I did, that I get to bear witness to this most amazing thing, this defining moment in a family's life. And as I, get off the elevator and I have to walk down the long corridor to the triage room, my eyes are all glassy and I'm all emotional. And I hear a couple of my colleagues kind of make a comment, oh God, who put her on triage, and I could just feel it, because I did kind of have this reputation, if you will, of being pretty expressive and emotive about the work that I did. And it's that reality that is the why. That is the why I did that work. And the environment, sometimes the environments that we work in don't really honor that. And you can feel really oppressed and suppressed in expressing your why. But I double dog dare you and really challenge you to be courageous in reconnecting with that why, because it's that piece that really needs to be the prevailing culture in our environments if we're going to create and sustain change, right? We have to really dig deep and connect with our shared humanity to really transform care, because that's the thing that is compelling. I mean, why else would you do this work if it didn't touch your heart and your soul and your mind? And I know that, I've done similar talks with other populations and invited people to say, why are you in the work that you do? And, some people will say, well, it's a steady job and it's a paycheck. And, if that's the reason why you're called to this work and you're embarking on a journey to transform care, you need to get your ducks in a row and you need to reconnect with the why. Because without the why, Barbara is not going to listen to you. The C-suite is not going to listen to you. And I'm not saying that you have to get up there in their face and cry and be all emotive and all that other kind of stuff. But what I'm saying is that why, that core purpose, that passion is what fuels you to choose your words, to choose the metrics, to choose the process that will also connect with the core passion in your colleagues and the core passion that's in the C-suite folks. Because even those guys, I mean, it may feel like they're a bunch of cold stones and they really don't get the good work and they're just about making money and that sort of thing. They could make money doing a lot of other things than being in healthcare. The majority of C-suite folks that have chosen healthcare do care about the patients. They do care about the quality. They do care about the experience. And so your ability to uncover your why and use that to connect with their why is going to help you set the stage for a successful transformation that not only changes things, but sustains things. And so it's the why that then pivots out to the how, which I'll next talk about, and then the what. And so the why, I kind of already talked about this, but the why is, why we've chosen neonatal care. Whether you're a nurse, a therapist, a physician, why have we chosen neonatology? I want you to think about that. I want you to reflect right now. Why did you choose this specialty? And there's no right or wrong answer. Dig deep. Because this, for me, this is why I get to touch the lives of people who are embarking on a whole new journey. This is a defining moment. Parents become parents when they have a baby, and you get to be there. And even though it is a crisis, you get to be part of that experience. And the things that you do and the things that you don't do will either have a positive or a negative impact on that experience. But if you dig deep and uncover the why, I'm pretty sure that you'll have a positive impact. How do we do this? And that's where we kind of come back to that relatively sterile but effective methodology. We choose those methods and we choose those processes. When you, the IHI has a really cool toolkit about quality improvement, and it takes you through a variety of different resources that can help you identify opportunities for improvement. So PDSA is one strategy that has really become pretty well known and super effective. But there's a variety of other things that you can look at, like failure modes and effects analysis is one that I also like to use. There's a variety of different tactics, if you will. But again, these are lost on everything if it is not underpinned by your why. What is the motivation? And even in the IHI, when you start looking at operationalizing the model for improvement, they invite you to identify what is your overarching aim. Why are you doing this? What are you trying to accomplish? And so that even that process begins with a why. And so that why has to make sense. It has to be measurable, but it also has to be driven from the energy that reflects your passion for this. And generally folks, I'm going to assume that generally folks come to these webinars or come to conferences and stuff. They're generally the part of the choir. We are the folks that we love this stuff. We can't get enough of this stuff. We're always looking for a new angle. I think that the angle of using that why is really going to help you be more effective in operationalizing the how bit. And then, of course, identifying after that what the what is. So here's the why, here's the how, and then, hold on. And then the what. And of course, my passion is around developmentally supportive care, trauma-informed care. And so when I talk about the what is the evidence-based practices that address those human dimensions of the patient's experience. So looking at how we protect the sleep, how we manage their pain and stress, how we prevent it ideally, ADLs, how we collaborate and integrate the family into the care team and the care of their infant and the healing environment as well. And so again, the resonance of these 5 core measures, how we can underpin them with our 5 core habits for improvers. So when we're looking at, for example, pain and stress, I'm working with a group now, and they're struggling around a variety of different challenges in preventing pain. People kind of roll their eye about that, like it's just an is thing in the NICU, although we can prevent it. But there's so many procedures that continually go unmanaged. And we know, this is the why bit. So we know from the science that unmanaged or undermanaged pain and stress changes the patient, not only at the cellular level, but at a genomic level. It changes them at that genomic level that then alters their developmental trajectory. And these individuals that suffer at our hands have a higher risk for, I'm using air quotes here, but that list of minor morbidities, you know, the minor morbidities that we don't talk about in the NICU because we're focused on survival and we're focused on those major morbidities. And the families, though, are then left picking up the pieces with these minor morbidities. But let me give you an example of one of the minor morbidities associated with NICU survivorship: major depression, autism, anxiety disorders, schizophrenia, increased risk for cardiovascular disease, an increased risk for metabolic syndrome. And though, I mean, these are lifelong quality of life, we're a little redundant there, quality of life busters that we could avert by reeling back, connecting with our why, and then once we understand our why, using the what is that is available to us through the literature, through evidence-based practices, to manage the experience in the now that will have a positive impact in the long term. So again, when I talked earlier about the systems thinking component core habit, as you embark on your improvement initiatives, it's important for you to do your due diligence, certainly understanding in the now event, right? So we know we've got the early life adversity research that's available to us. We're now seeing these different genetic markers that indicate that the patient has had adversity or toxic stress. These are genes that influence the operationalization of your serotonergic system. It alters dopamine function, and these are just methylations, all right, modifications to your genome as a result of toxic stress. So if we know this, which we need to, that's part of the work that you do when you're embarking on transformation, when you're embarking on adopting a new culture of care and making that your standard, your due diligence phase is looking at the research, understanding the biology. And then as a systems thinker, you are connecting that biology to short-term and long-term outcomes that certainly align with the humanity, with the individual and their family. But you can take that a step further and look at how the improvement work that you do will also benefit the hospital, the society at large. Certainly you can throw insurance companies in there and all that sort of thing. When we look at what's called the burden of disease, we as clinicians who care for individuals who, at the beginning of their life, we have an enormous amount of power and we have an enormous amount of responsibility. And we have to take that, own that, walk in that power and connect the dots. And as you start processing all of this information, I invite you to read this paper really thoroughly and start figuring out how you're going to hardwire these habits into your current routines. What you will find is more and more people are going to listen to you. More and more people will be engaged in the work that you're doing. You won't have as many resistors because people will be impassioned just as you are, because you, as that change agent, as that pioneer, will be connecting the dots to the things that align to the core values of your colleagues and the core values of your hospital and society at large. So I think, you know, what I'm really kind of hopefully helping you understand is that even though on first blush it may look like improvement work is just about numbers and metrics and managing and, you know, applying this PDSA thing, it actually is much bigger than that, because if you don't have that passion behind it, it will not get hardwired. It'll just fluff right off, just like those you know, the flowers that you blow and all the little things blow away. I don't know what you call them. But that's what will happen. Any work that you do, if you don't connect it to core values, to core passions, then it will just disappear. This is why when you're doing improvement work, it's important. The management piece, measuring and managing the process, is really important because it reminds folks to stay connected to it. Do you know how many times you have to hit somebody up to remember something and have it then translate into a habit? It's something like 66 times, or 66 days to establish a new habit. So it's 66 days of doing the same thing to break your old habit and embrace a new habit. And that's what you guys need to do. So you guys, you're all on this webinar. You guys are the champions. You're hearing this, you're understanding this, you're going to reflect on it, you're going to process it and internalize it, and then you're going to check it out. You're going to connect with your passion and your why, and then see how that translates into the actions that you do in your improvement work. And you'll be blown away, honest and truly. I mean, the group that I alluded to a little bit ago, so I've got a group of folks, they're participating in this Quantum Leap program. And this Quantum Leap program really was my brainchild to connect the work that I had done previously with Children's Healthcare of Atlanta, which was very much driven by the evidence, which is critical, and the process of the PDSA methodology and keeping people engaged to transform the environment of care and adopt the NAN core measures, the NAN clinical practice guidelines for developmental care. The discovery, though, after that 3-year program was that after I left, things started to backslide, and they were struggling with sustaining the gains that they had achieved while we were working together. And I kind of liken it to me being like the principal, you know, I'm coming back in to check. And so I knew there was a flurry of activity like the week before I was coming back on site for people to kind of do the things that, you know, had fallen behind. And this isn't, I'm not saying this with any judgment at all. This is like what it's like to be a human being, right, with multiple competing priorities. And so I brainstormed with my point person there and other folks to really try and understand what did I miss? What was that, where's the gap in helping folks sustain those gains? And it was when I invested in some coaching for myself to really, you know, kind of become more competent as an entrepreneur and that sort of thing, that I bumped into this amazing woman who is a high performance coach. And her whole gig is about cultivating courage and competence within yourself around your skills, what I now call as the soul track. And it's really a fusion of both your skills, your technical skills, and your knowledge around evidence-based best practices that has to be connected to your internal sense of self, your soul, and using that fire of your soul and your passion to create habits that will facilitate improvement in the short term, but also in the sustaining of those gains that you've achieved during your improvement initiative. So the meaning of things lies not in the things themselves, but in our attitude towards them. We're talking about a mind shift. How do we connect and honor the fact that, you know what, I love being a nurse. And I know that the work of nursing is profoundly valuable. And I work in a system that, and this is I'm just speaking about North America right now, but I work in a system that doesn't value the work of nursing to the degree that is necessary. Nursing services get bundled into the price of your bed. And so with the price of your hospital bed, you get a licensed nurse. She could be wicked awesome. She could be Florence Nightingale, or she could be somebody who's just marginal, but they got a license. And Florence and the marginal nurse may have two different views of what quality care looks like. And so we need to kind of reshift what our expectations are of ourselves and evaluate what that looks like in connection with evidence-based practice and the passion that we have within ourselves, the why, to provide evidence-based best practice. And our goal, of course, is in better service to others. And that is the secret sauce. That is the thing that helps us stay aligned with our purpose and keep our eye on the prize, which is quality and patient safety.
There's an African-American song, 19th century, which is so great. It says, when it looked like the sun wasn't gonna shine anymore, God put a rainbow in the clouds. Imagine. And I've had so many rainbows in my clouds. I had a lot of clouds, but I have had so many rainbows. And one of the things I do when I step up on a stage, when I stand up to translate, when I go to teach my classes, when I go to direct a movie, I bring everyone who has ever been kind to me with me. Black, white, Asian, Spanish-speaking, Native American, gay, straight, everybody. I say, come with me. I'm going on the stage. Come with me, I need you now. Long dead, you see? So I don't ever feel I have no help. I've had rainbows in my clouds. And the thing to do, it seems to me, is to prepare yourself so that you can be a rainbow in somebody else's cloud. Somebody who may not look like you, may not call God the same name you call God, if they call God at all, you see? I may not eat the same dishes prepared the way you do, may not dance your dances, or speak your language, but be a blessing to somebody. That's what I think.
And isn't that really the work of what we do? That, you know, what Maya Angelou was presenting there was really helping us reconnect with our why. And so for this, you know, kind of wrap up of my talk here, we talked about the tactical bits, we talked about the why and the how and the what, but there's also a reflective component to this to really help us fully understand the importance of what we do and the opportunity that we have to do that work. Creating and sustaining transformation begins with an understanding of who I am and why I do this work. And we cannot give what we do not know. We are all humans. We are humans. We connect with our patients and our families. But if we don't connect, remember that sub-element of the habit of being an influencer is having empathy. We need to empathize with the lived experience of our patients if we're really going to care, and if we're really going to get other folks to care to help us make things better. What clouds have come into your life, and what were those rainbows, and how did it feel? How did it feel when you were having those clouds? Because you know the families that we serve in the NICU, it's a pretty cloudy day, every day, for as long as they're there. But how wicked awesome is it if you get to be that rainbow and connect with what it feels like to be a rainbow in someone else's life? I have a myriad of experiences that I'm really grateful for where I got to be a rainbow for my patients, and that is what has fueled me on my journey to do the work that I do. And the work that I do is really aimed at helping you be the best version of yourself, be the brightest rainbow during the darkest clouds, during the darkest day of these people that we serve. We cannot give what we do not have, though. And that's that whole thing around, you know, when you're on an airplane and they say, put the oxygen mask on yourself first before you help others. Well, there's a reason for that. You know, if you don't put the mask on yourself, you may be sitting next to a knucklehead who doesn't know how to put the mask on you. And even though you helped that person, you're dead. And that's what we do. I know my default reference point is nurses, but it is, you'll see, you know, how burnt out nurses are. I believe that that's what Barbara's affliction is. I think Barbara has lost sight with her core passion and with her sense of why. why she does the good work. And she doesn't realize that she too can be a rainbow. And it's that piece that really helps us do the good work, create and sustain change. And these things, I mean, they may seem fluffy, but these are grounded in evidence. We know this. And so it all begins. It begins with habits. And creating habits can be difficult, but it's taking baby steps. One person shared a really cool metaphor and said, how do you eat an elephant? One bite at a time. How do you do this improvement work? How do you create and transform a culture of care? One step at a time. And beginning that with why. And beginning that with identifying and establishing new habits.
If you want to change the world, start off by making your bed. If you make your bed every morning, you will have accomplished the first task of the day. It will give you a small sense of pride, and it will encourage you to do another task, and another, and another. And by the end of the day, that one task completed will have turned into many tasks completed. Making your bed will also reinforce the fact that the little things in life matter. If you can't do the little things right, you'll never be able to do the big things right. And if by chance you have a miserable day, you will come home to a bed that is made, that you made. And a made bed gives you encouragement that tomorrow will be better. To pass SEAL training, there are a series of long swims that must be completed. One is the night swim. Before the swim, the instructors joyfully brief the students on all the species of sharks that inhabit the waters off San Clemente. They assure you, however, that no student has ever been eaten by a shark, at least not that they can remember. But you are also taught that if a shark begins to circle your position, stand your ground. Do not swim away. Do not act afraid. And if the shark, hungry for a midnight snack, darts towards you, then summons up all your strength and punch him in the snout, and he will turn and swim away. There are a lot of sharks in the world. If you hope to complete the swim, you will have to deal with them. So if you want to change the world, don't back down from the sharks. Over a few weeks of difficult training, my SEAL class, which started with 150 men, was down to just 42. There were now 6 boat crews of 7 men each. I was in the boat with the tall guys, but the best boat crew we had was made up of the little guys, the Munchkin crew, we call them. No one was over 5'5". The Munchkin boat crew had 1 American Indian, 1 African American, 1 Polish American, 1 Greek American, 1 Italian American, and 2 tough kids from the Midwest. They out-paddled, outran, and outswam all the other boat crews. The big men in the other boat crews would always make good-natured fun of the tiny little flippers the Munchkins put on their tiny little feet prior to every swim. But somehow these little guys, from every corner of the nation and the world, always had the last laugh, swimming faster than everyone and reaching the shore long before the rest of us. SEAL training was a great equalizer. Nothing mattered but your will to succeed, not your color, not your ethnic background, not your education, not your social status. If you want to change the world, measure a person by the size of their heart, not by the size of their flippers. The 9th week of training is referred to as Hell Week. It is 6 days of no sleep, constant physical and mental harassment, and 1 special day at the Mud Flats. The Mud Flats are an area between San Diego and Tijuana where the water runs off and creates the Tijuana Sloughs, a swampy patch of terrain where the mud will engulf you. It is on Wednesday of Hell Week that you paddle out in the mud flats and spend the next 15 hours trying to survive the freezing cold, the howling wind, and the incessant pressure to quit from the instructors. As the sun began to set that Wednesday evening, my training class, having committed some egregious infraction of rules, was ordered into the mud. The mud consumed each man until there was nothing visible on our heads. The instructors told us we could leave the mud if only 5 men would quit. Only 5 men, just 5 men, and we could get out of the oppressive cold. Looking around the mud flat, it was apparent that some students were about to give up. It was still over 8 hours till the sun came up. 8 more hours of bone-chilling cold. The chattering teeth and the shivering moans of the trainees were so loud, it was hard to hear anything. And then one voice began to echo through the night. One voice raised in song. The song was terribly out of tune, but sung with great enthusiasm. One voice became 2, and 2 became 3, and before long, everyone in the class was singing. The instructors threatened us with more time in the mud if we kept up the singing, but the singing persisted, and somehow the mud seemed a little warmer, and the wind a little tamer, and the dawn not so far away. If I have learned anything in my time traveling the world, it is the power of hope. The power of one person, a Washington, a Lincoln, King, Mandela, and even a young girl from Pakistan, Malala. One person can change the world by giving people hope. So if you want to change the world, start each day with a task completed. Find someone to help you through life. Respect everyone. Know that life is not fair and that you will fail often. But if you take some risks, step up when the times are the toughest, face down the bullies, lift up the downtrodden, and never, ever give up. If you do these things, the next generation and the generations that follow will live in a world far better than the one we have today. And what started here will indeed have changed the world for the better.
Now, I'm not trying to suggest that improvement work is as dramatic as SEAL training, but I hope that the messages that that gentleman was sharing with you ring true. You can change the world, or you actually are the world, to the families that we take care of in the neonatal intensive care unit. They look to you for everything. Let that connection fuel your why and take you on that journey to cultivate the habits of improvers and engage all your colleagues all the way up to the C-suite level to transform that experience of care. In doing so, you will absolutely achieve sustainable results that will transform not only your patients, not only their families, but you as well. So I'm just gonna stop talking now and open it up to questions. I hope you found that interesting.
Awesome, Mary. Thank you so much. And, you know, I personally want to thank you for always being a bright and shiny rainbow to all the babies and the families and the staff out there. I worked with Mary for a long time, and she shines bright, let me tell you, all the time. So we do want to open up to questions. Down below, if you hover over the bottom of your screen, you'll see a little thing that says Q&A. So if you have any questions, if you just want to type them in there, Mary will be happy to answer them. So Kathy, I'll turn it over to you to help Mary field the questions.
Sure. So I think just really going, again, Mary, amazing presentation. I loved every second. And so kind of going along with just those even last points you were making about really changing things. So Kathleen's asked a question about how to get that higher level management buy-in. How do you get them to feel your vision? And she's saying that her unit would transform if, you know, one person could do it full time, but they don't have that funding. And it seems that no one in the upper management yet understands this link between the NICU and this long-term burden of disease. So what are your pointers for getting people in the higher levels of management to listen?
I think one of the first things that you need to do is you need to understand what is the current dashboard for the executive team. So, you know, if you're a nurse, you know, you could connect with the chief nursing officer or the chief operations officer if you're in allied health to try and really understand what is on their current dashboard. What are the metrics that they're currently looking at? Pretty much universally, people are looking at patient satisfaction, obviously the HCAHPS scores, obviously length of stay and any other types of complications. When I worked with the CHOA folks, what they started to do is looked at hospital-acquired conditions that their organization was really committed to reducing the incidence of hospital-acquired conditions. And so understanding that as a priority, what this group did is they identified what are hospital-acquired conditions for the neonate. Now, certainly there's the obvious ones about, CLABSI and surgical site infection and things like that. But what they also pointed out and put forth was the experience of unmanaged pain. And they had done some really cool work looking at, but correlating big data, so the vital sign data, with pain assessment and pain management. And they were then able to connect that improvement initiative around improving and achieving consistency and reliability in assessing pain and then managing it to reducing hospital-acquired conditions. So you have to know what the language is. It really is that kind of a challenge for us, because again, you're absolutely right. They have no idea what the NICU is. They just know that it's, it seems to generate some good income and they do little people, and that's the end of it, but they don't understand the breadth of it. So when you're looking at identifying it, you want to align your project improvement with the metrics that they're interested in, and then engage them. Set up a meeting before you start backing up a tree and getting all frustrated. Sit down and talk to them. Share the knowledge that you've accrued with them. And you may have to go up the chain of command. I mean, I know, first you want to speak with the nurse manager, but reach out. The majority of hospitals have QI committees. And again, the work that I focus on, this work that I'm presenting to you, is a quality and patient safety initiative. We know that people that experience toxic stress have an increased vulnerability for infections because of the immune perturbations. We know, also these genomic issues that I talked about earlier. We know it, but nobody else does. So there's a process of educating folks that can feel frustrating. But again, when you look at the paper around the habits of improvers, that's part of your due diligence to make those connections. I admire it. It's an excellent question, and many people struggle with that very same thing. So I hope that this response was helpful. But also, Catherine and anybody else that is on the webinar, please feel free to shoot me an email. I'm happy to answer any questions that may pop up after you've left the webinar as well.
Excellent, Mary, thanks. That's a great question.
Oh, good, Kathleen, thanks, good.
There's somebody, Michelle is asking, as a developmental specialist with HRIF or high-risk infant follow-up background, how do I impact the how of what we do in the NICU? And because it can make a lasting impact on the infants as they go through life. So how does the developmental specialist, I guess is that Michelle, your question, how do you make a difference on the how?
And the how part, that was the PDSA bit, right? So the why was the passion. The how was through, either PDSA or doing a failure modes and effects analysis. And then the what is the best practices. So the how bit, of course, it depends on where you're focusing on, but you have a breadth of insight and knowledge that many bedside clinicians who have, done all their time inpatient are unaware of. So your peek into the future can really be of value, sharing that to those frontline clinicians. I know a lot of times, we get invited, when I was first starting, oh, do you want to come over to Children's and you can see the follow-up clinic? And I didn't want to do that. I just thought it was boring, and I'm just being honest. I had no insight to what follow-up was all about. I just knew it was outpatient, and outpatient, I'm an adrenaline junkie. I don't like that. So what you have a supreme opportunity to take your knowledge about what you see about NICU graduates and bring it back into the NICU. Part of the how, so PDSA could be around educating staff about this. I want people to see what they don't see when the baby is, wrapped up in a cute little bunny bunting and about to go out the door with their parents. I mean, everybody looks good dressed up that way, but they don't know that pales in comparison to what's going down the road. Michelle, I got to work with these amazing parents out of Children's in Dartmouth, who did an amazing presentation, and they actually videotaped their own children who are now teenagers and graduating from high school. And they talked about the challenges growing up, and specifically, some of their learning challenges, but all three of these children had major depression and that sort of thing, and the power of videos. And so for you, Michelle, I think the best thing to kind of get the ball rolling is to capture some video, capture some testimonial, capture that impactful, passionate human stuff that, nobody can turn a blind eye to that, that you really want to punch them in the solar plexus with the emotion of what the long-term outcomes are, and then use that as the why we need to change what we're doing here. And the thing that's really can be frustrating, but it can also be joyful, is that developmentally supportive care is disease independent. All babies will benefit from this. All families will benefit from this. And so that generalizability of these practices really will help you, if you're still in that follow-up clinic area. Maybe, you draw that line in the sand and you're going to say, we're going to start watching the outcomes now that we're doing these different practices, and how are we seeing better outcomes. In the pilot study, when we launched the core measures, the original core measures, we saw not only short-term returns, but we followed the patient cohort to 2 years of age, and we saw a dramatic decrease in the incidence of internalizing, externalizing behaviors. We saw better sleep for these patients. It was really remarkable. So I think what you will bring to the project will be brilliant and transformative in and of itself.
Excellent, thanks. And great question, Michelle. And I'll just echo what Mary said, is I think that when people are given the opportunity to come to follow-up clinic, it is life-changing, I think, for our practice. And your eyes just peel open with a whole new world. So that's a great thing to do. And one of the solutions we've done at a couple of the hospitals where I've worked is most nurses work 3/12, so that's 36, and they can do up to 4 hours before it's overtime. And we've been able to arrange for the nurses to go to the clinic for 4 hours, so it's not overtime, and they can do it during a work week. So that's been the way we've managed it for staffing. So no one has to have a day off to go do it, but we pay them for the time to do it. So just an idea for you too, Michelle, on that.
Mm-hmm.
There's a couple people raising their hands. So I'm not just sure if you're just raising your hand like in church with an amen. They're just high-fiving you, Mary, or if they actually have questions. So a few of the hands that are up, I don't know if you guys want to type in your questions. You're just, again, kind of applauding or something with your hand waving.
But this is Kathy Bush again. Just a quick aside while people are seeing if they're going to type things in. Mary, those little flyaway things that you couldn't remember the name of, those are dandelions.
Oh, thank you very much.
And those cute little dandelions fly away, and ironically, and they land and create new flowers. So I don't want you to think of, blowing on the dandelion and that ends up going nowhere. It actually creates new life. So I want you to transform forever your thinking about those.
That is silly little. Thank you.
Oh, I love that.
That's hilarious.
All right,
trying to give you a little heads up, Mary. They're like, dandelion.
I didn't have any of those boxes down. I was just focusing on my slides. I didn't want to get distracted. So thank you. I appreciate you guys, the guidance for the sound. I hope it resolved.
Yep, you were fine.
Great.
So let's just move on. I think we're done with the questions. So in order to receive your free CE, you can either click on the link provided over there on the side, or you can wait to get the recording. And there'll also be a link to the evaluation there. If you are watching the recording, just go back to the email you received with the link to the recording, and if you click on the link to the evaluation form, you can just fill it out, and at the end of filling it out, you receive a link to the CE certificate. And if you don't have time to do it today, you can, again, always come back and do it on another day. If you are viewing as a group, and I had several people email me that are watching as groups today, you must each individually log into the evaluation form in order to get the CE. We do have many recorded webinars that are still available for CE on the DandleLION website, so be sure to go back there if you're looking for other CEs or you want to hear other great presentations. I hope that you will like DandleLION on Facebook. We're trying to do a better job of keeping that current. And we do launch all our new products via Facebook. Initially, you're the first people to find out. And we just launched a new product called the Cozy Cub. That is a bead-filled boundary that works with babies of all sizes to help their individual positioning needs. In the evaluation, there'll be a little checkbox there, and if you want more information about the Cozy Cub, we'd love to send it to you. We also have 2 new products that are going to be launching in this quarter, so like us on Facebook and you'll find out quickly. So anyway, just to sum it up, Mary, thanks so much for being our rainbow this morning and for sharing your great information. And, you know, let's face it, the why, that's, if we could all lead life with our why ahead of us, I think that the world would be a better place, no less, all of us better people. So thank you for your really motivating and inspiring presentation. We appreciate that, and we appreciate all of you that listened live today and those of you who will be listening to the recording. We do have one more thing. Can you repeat how to fill out the CE? So Kathy, can you post the link to the evaluations over in the chat box? So just click on that and you'll get right to the link. So Mira, thanks again. Thank you, everyone. Have a great weekend.
Thank you very much. Take care.
Yeah, I'll stay on a few seconds so that you guys can grab the link to the CE. Otherwise, later today, we'll send out another email with the update with where you can view the recording, as well as where you can click the link to do the continuing education. And again, if you're a group, when you get the email, you can just distribute the email out to everyone who attended and they can fill in that as well.